In our last webinar, we discussed ablation strategies for ischemic and non-ischemic VT using the inHEART platform. And you both shared some very specific case studies where the information from the inHEART maps was able to help you make really important treatment decisions. But in order to generate those maps, you need CT and MRI images of the patient's heart and surrounding structures. So let's start today's discussion with having you give us an overview of the specific imaging requirements for these CT and MRI images. Hubert, I'll turn it over to you.
Yes, thanks, Katie. Yes, you're right. We should start by that, by acquiring images, because the better the images, the better the service that inHEART can provide, obviously. So there are numerous ways of acquiring imaging of the heart, and the inHEART solution incorporates most of them. Here is a slide that shows the most available technique, which is arterial-enhanced CT. So it's the same thing as a coronary CT, except that the injection protocol is slightly different because we need enhancement in both the LV here and the RV in order to visualize also the right ventricular structures and the thickness of the septum. But apart from that, it's a very standard cardiac CT acquisition. The only differences with respect to classic cardiac CTs is first this injection protocol, which has to be slightly modified, but the inHEART team can assist you in doing that. Then there's the coverage also. We need the aortic arch or the pulmonary arteries, and you will see why. Pierre will tell you that these are critical structures to obtain optimal registration during the procedure. And then we need these to be acquired during mid-diastole, meaning that it's the maximum volume, so the volume matches well with electroanatomical mapping systems. And in this very standard acquisition, there's a lot of information. There's a lot of anatomical information, but also substrate information. We can extract from these images maps of wall thickness, maps of intramural fat or calcification, and this helps us guiding catheter ablation in most patients, particularly in post-infarction patients. In some patients, there are intramural scars in areas with preserved thickness, and in these, we need late enhancement imaging. And for that, the best way to go is to use MR. So this is the second method that I will show, is the late enhancement CMR technique. So this is a technique that maps the accumulation of gadolinium and the late phase in the scar because there's less viable tissue. So the distribution of the gadolinium is, the volume of distribution is higher and the concentration is higher. But if you ask that to your imaging department, most of the time they will do this, which is the conventional way of doing late GAD-MR. It's during one breath hold, you acquire images of the heart. The spatial resolution of that is limited. The slice thickness can go up to 8 millimeters. So the description of the scar will be quite limited also. There's another way to do it, is high-res three-dimensional late GAD-MR. And this is a different technique that is acquired during free breathing thanks to a monitoring of the diaphragmatic motion. And this gives access to much lower spatial resolution in the range of 1 to 1.5 cubic millimeters. And this is the way to go if you want a detailed scar characterization in your lab. So again, the inHEART team has protocols for most vendors of CMR systems and can assist your imaging teams in developing these. The problem with MR is that very often there are ICD artifacts, and these images are heavily hampered by these artifacts. For that reason, we are often implementing in centers late iodine-enhanced CT. So it's the same thing as late GAD-MR, but with CT. You see here an arterial phase CT, here a late iodine-enhanced CT showing an inferior infarct. These two images can be fused, and you can have the spatial resolution of the arterial CT and the late iodine CT showing the scar distribution. And this matches very well with the scar as mapped from MR. So again, there are multiple ways of accessing the scar. Arterial enhanced CT is easy, doable everywhere and answers the question for the majority of patients. But sometimes you need late enhanced imaging, either with MR or with CT, depending on the presence of ICD artifacts and the availability of the methods in your center.
Hubert, can you tell us a little bit more about what late iodine enhancement, or LIE, is for CT?
Yeah, sure. So this is a method that is less known than late enhancement CMR. So late enhancement CMR has been known for now 3 decades as the gold standard to image scars in patients. Late iodine enhanced CT is exactly the same principle. So you inject iodine instead of injecting gadolinium. And at the late phase, a bit earlier than on MR, we usually image at 8 minutes post-contrast, you image the heart. And the idea is that the iodine will accumulate in these scars because there are fewer myocytes. It's a matrix of collagen with very few cells. And these contrast media, gadolinium or iodine, have a higher concentration there because there's less cells. These are extracellular tracers, so they accumulate. And then you can see this contrast. So the issue with CT is that it's a bit more noisy than on CMR. You can see here an anterior infarct with no reflow. It was a recent infarct. Here an inferior infarct. Here an intramural scar, and here a subepicardial scar. And there's a little bit more noise. You see the comparison to CMR in this patient with non-ischemic cardiomyopathy or in this patient with infarct. There's a bit more noise, but there's a higher spatial resolution. You take advantage of the spatial resolution of CT, which is 0.5 millimeter. And maybe we'll get to there later, but the artifacts from the ICD is much lower than on MR. There's just the lead that is hampering a bit the septal assessment, but for the rest of the heart, it's okay.
So is LIE on CT needed for all patients, or does it vary?
No, it varies. So as I said earlier, the arterial enhanced CT, so the classic cardiac CT during the first pass of iodine, does the job for most patients. In fact, it's important to understand when these additional methods, late GAD-MR or late iodine CT, are needed because they are less available and sometimes tricky to acquire, either because there's an ICD or because of the renal function, because the late enhanced CT requires additional iodine contrast. So in patients with renal dysfunction, it can be a bit problematic. So our strategy to define the optimal protocol is this one. So in post-infarction, the arterial enhanced CT does the job for most patients, and you will be able to work in your lab with wall thickness maps, fat maps, calcification maps. In ARVC, it's the same. The arterial enhanced CT does the job because we can map the anatomy and also the intramural fat in the right ventricular wall. But it's in non-ischemic cardiomyopathy that you need this contrast within the wall with either late CT or late MR, because the arterial enhanced CT can be totally normal. You won't be able to detect these intramural or subepicardial scar if there's no wall thinning associated to it. So we add this late CT or late MR in NICM almost only, because it provides a perfect assessment of the substrate, and we render these in the form of maps of late enhancement, dense scar, and gray zone to understand the channels of gray zone that may be pro-arrhythmogenic.
So Hubert, can you also tell us a little bit about the impact that an ICD has on the MRI or the CT images?
Yes, this is important because this is a major limitation of MR. It also has an impact on CT, but to a lower extent. I will show you images to illustrate that again. I'm jumping back and forth in my slides. So here you see the issue with CT is the leads. The CAN is not an issue. It would be an issue if you were to image the CAN area, but the CAN is above the heart. The problem is that these leads, and particularly the tip of the ICD lead, leads to streak artifacts that can sometimes hamper the analysis of the septum, particularly. But this is only at the level of the lead. So it's a minimal artifact. you see it's only impairing this characterization, but immediately above, it's okay, and below, it's okay. So this is not major. It can be limited using techniques like iterative reconstruction to address these metal artifacts, but it's not a major issue. On MR, it's a much more bigger issue, because if the patient is small enough, and if the can of the ICD is low enough, then it will induce susceptibility artifacts that may cover the entire cardiac area. So there are means to diminish this artifact by using specific sequences that diminish this signal void. But it is not working very well in every patient, and particularly in patients with lower implanted cans or with subcutaneous ICDs. You don't see the heart, you know.
Jody, we are getting some questions, if I could interject here. So, Hubert, one of the Q&A that has come in is LIE specific and reliable in showing EPI, endo, or mid myocardium?
Yes, definitely. It's analyzed as you would analyze an MR. The only thing is it's a bit more tricky to obtain nice images than on MR. So for that, you need to optimize a protocol. And at inHEART, we are exposed to a sufficient number of different sites with different vendors, so we can share protocols between vendors. But it's only doable on recent CT scanners. To obtain a good contrast, you need both a tube that can deliver enough current and detectors that are sensitive enough not to have too much noise, you know. So recent CT scanners in most vendors do a very good job in mapping that. In any case, it's always better than an MR with a lot of artifacts, you know. And plus, if I may add, the next generation of cardiac CTs will totally change the game in that domain. The photon counting CT detectors are coming. The first system is now ready for clinical use. And this will largely improve the way we characterize the myocardium on imaging, with both a better contrast and a better resolution.
I have a question for you, Hubert, if I may. You beautifully shown the impact of the ICD can on MRI images with this completely black area. And then with wideband, for example, you can get access again to some images. Do you get the same image quality and the same spatial resolution with this MR sequence as you would otherwise?
Well, again, it depends on the case. The spatial resolution is not impacted. The problem is that it's a method that allows you to diminish the size of this signal void coming from the can. So if you're lucky, this will be sufficient for you to cover the entire heart. But then it has another impact, is that the contrast is a bit flattened. The gain is not the same as in the gold standard LG CMR sequences. So it helps a lot, but the variation in late GAD intensity is impacted by these wideband techniques. But in any case, I would advise any sites willing to do CMR in patients with ICDs to get equipped with these sequences, because it helps a lot, even beyond the problem of VT ablation. It's important for these patients.
So we have one more question, this one coming from a chat. A physician is asking, can they use MRI acquired years before, like prior to the ICD implant?
Yes, sure. And it's the best strategy to get nice quality images is to perform MRI before every ICD implant in your center. There's a rationale for that. So of course, it's not doable everywhere, because maybe you implant more ICDs than you do cardiac MRIs. But the rationale for that is that when doing so, for primary prevention, you're measuring LVEF to select patients for ICDs using the gold standard, because CMR is the gold standard for that. And you also have access to the size and heterogeneity of the scar, which is an important factor in making the decision when you're not certain whether seeing a large scar, very heterogeneous scar, may incite you to implant an ICD for primary prevention. Plus, and this is what you're mentioning, Katie, you will get this scar with very good quality available if the patient comes back with shocks. And this can be in years. We've been guiding VT ablations based on MR data dating for years ago. And we have means to register it to the current anatomy. So if you require an updated cardiac CT, we can wrap the old MR on in this cardiac CT coordinates, and then you will work with fused information.
All right, well, thank you. And I'd like to remind attendees, you can put questions into the Q&A in the chat. So continue to do so as we move forward with the dialogue.
Thank you.
Jody, I'll turn it back to you.
Sure, thanks, Katie. So Pierre, I have a question for you now. So in what situations is it preferable to sacrifice spatial resolution and anatomical detail that you get from CT for the substrate identification that you get with LGE in MRI?
Yeah, you know, this largely depends on the type of underlying condition we're talking about. Really, when it comes to post-myocardial infarction, VT, my favorite option is to get a CT scan and get those wall thickness map that are very accurate and that are very robust, in fact, because they show you the area in the scar that is critical to the VT circuits. And I really think that in over 95% of post-MI VT, CT is in fact probably superior to MRI. Now, if you have a patient with non-ischemic cardiomyopathy, then it's completely different. Only 50% of them at most have some degree of wall thinning. So the characterization of substrate using this strategy is not working very well with CT scan. And this is where you have to go to MRI. And as Hubert mentioned earlier, obviously it's not the same spatial resolution, but still with high resolution MR sequences, you get access to something that is 1.2 millimeters voxel side. So it's quite acceptable. And it's really, you know, the worst case scenario for us is when we have a patient referred for VT ablation. We have a substrate that is not endocardial, meaning that voltage mapping is not going to work and the patient is not even inducible for his VT, or the VT is not tolerated, meaning we're blinded. The only thing we can do is pace mapping, and that's not very efficient. So having some imaging in those patients is absolutely critical, and then MRI is the best modality.
Thank you, Pierre. So, Hubert, I think this is a question for you now. How can physicians assess if their CT scanner is adequate for late iodine CT?
Well, before launching every site with the inHEART technology, we inquire as to what systems are available locally. And we can share protocols between sites. So I can't go over all the CT systems available here, but the most recent CT scanner generations, or not the photon counting ones, but the prior ones, are able to do it, and we can share protocols for that. And if you want to inquire specifically if your CT scanner is able to do it, I advise you to contact the help desk at inHEART, because they do that every day. In fact, that is part of their job. During the launching of every site, over the first dozens of cases, the image quality improves, and we see that both on our tail and on CT, late and on CT and MR, we can assist the sites in optimizing the images. This is in our interest.
Yeah. So another question that we have from physicians is, so now that they've acquired all of these beautiful MRI and CT images of the heart, what does the workflow look like post-acquisition?
Yeah, this is an important question because the way inHEART operates is a bit different from other software technologies. We've opted not to have the image processing being done on site because we believe that very few sites will have the expertise in segmenting the data. And we believe that it allows us to monitor the quality of images, and also with respect to turnaround times, it's even more effective because apart from very specific centers, high academic centers, I think it's no one's job in any hospital, both in the radiology department or imaging department and the EP department. It's not their job. So the workflow is, once the image is acquired, it's uploaded on the cloud. So we provide an account to a web portal, and the data is uploaded anonymized. inHEART doesn't keep any patient information attached to these files. And then we process the data. So we have case analysts in Bordeaux working on processing data every day. And in a matter of hours, the client receives a notification that the case is ready. He can connect to his web page or his portal and review the case, annotate the case, show the case to his staff, to the patient, and then export it to navigation systems. Maybe we'll get to there later. Maybe I'll provide a short demo.
Sure, absolutely. So when it comes to atrial versus ventricle models, Pierre, I think this is a good question for you. What is the importance of image timing in systole versus in diastole in relation to image registration on 3D electroanatomical mapping systems?
Yeah, this is a very important question. Thank you very much, Jody, for asking. It is important because if you work in the ventricle, sorry, I should start by saying that when you work with your navigation system, you're going to work in diastole, in the chamber of interest. So if you work in the ventricle, you're going to have your anatomy that is acquired in diastole, so the biggest volume. And if you want that to match with the images that are reconstructed, then it means that those images have to be acquired at the same time of the cardiac cycles, so in diastole. And the importance is that if you try to register the model of your patient that is reconstructed from MR or CT, and that has been acquired during end diastole, if you want to do the registration process using the atria, then it doesn't work because the atria in your navigation system are going to be mapped in diastole of the atria, which means systole in the ventricles. So it's a mismatch, and this simply doesn't work. So it's really important to realize that. And if you want to work in the atria, then you have to specify that your CT scan or MR has to be made in diastole of the atria and not in diastole of the ventricles. That's very important. And it also explained the strategy for the registration, but I think we'll see that later.
Good, good. So are the inHEART, and you're talking a bit about this registration with the electroanatomical mapping system. So are the inHEART images compatible for import into all current electroanatomical systems?
Yes, absolutely. Yes, every system. So that includes Carto system, of course, but the Rhythmia system as well. The Insight system from Abbott, Stereotaxis is compatible as well. Yeah, that's so. In fact, when you get to the portal and upload your case, you just explain what is the condition that you want to perform VT ablation in that patient, and you specify which system, which navigation system you're going to use. And the engineers here at inHEART Solutions will adjust the format accordingly.
Wow, that's great.
We do have some questions that have come in. Let me take the one off of the Q&A first. So Pierre, I'm thinking this would go to you. Can you comment on the workflow for assisting VT radioablation? And is there a way to register the ablation targets that you segment on a diagnostic image back to a radiation planning CT?
Absolutely. But, I've not been really involved in that because it's something that is done by radio ablationists. So Hubert, I think he's more qualified than I am.
Okay, sorry. Hubert, please. You muted.
You're on mute.
Yes, in
Minor
fact,
detail.
we've been doing that. So it's not something that is part of inHEART products, but I can comment on that because we're doing research on that. So inHEART does 3D modeling, and we can use these 3D models to assist stereotactic radiation therapy. But for that, you need a specific software in order to trace the targets, register electroanatomical maps and everything. And this is not yet part of inHEART products, but maybe I can show what we're doing in that prospect. So it all starts with the inHEART models. So for instance, this patient was a patient from Toulouse, from our good friend Philippe Maury. He had this very large anterior infarct that is mapped using wall thickness. And Philippe could not enter his LV to ablate his VT because there was this very large clot on the LV apex. So what he did is an epicardial procedure using the high density mapping. So it was a arrhythmia system. During sinus rhythm, he could not map the VT. So what this mapping showed was an anterior channel here that was also visible on this thickness map. We will get that later. And then based on these two informations, he traced a target on the volume. And then we can export this target along with structures at risk that may be damaged during ablation in the format that is suitable for SBRT planning systems. So it's called the RT-struct format. So we've been doing that in about 50 cases in multiple sites. In fact, the Brigham is the most active sites. They've been doing 10 to 15 cases with our technology. And it's very variable. Of course, for now, it's a last resort technique that is used in the context of compassionate use. So sometimes we only have imaging, very rarely, but sometimes we only have imaging because the patient has two mechanical valves. It's impossible to access the LV. Sometimes, and most of the time, we have prior EP maps because the patient has undergone multiple failed ablation, and we can use that to refine the target. And yeah, so it's doable. It's not yet a product delivered by inHEART, but it's leveraging on obviously the capacities of inHEART to map the anatomy, the substrate, and to transfer that in the EP world.
Great.
Okay.
The next question for our speakers is regarding cardiac radiotherapy, SBRT. Is there any tool to facilitate planning treating volume, PTV, to 4D CT scan of rad-onc colleges? And then the question goes on to say, I mean, creating the volume to treat with inHEART and then export in file compatible for rad-oncs.
Yes, this is what I just showed. So okay. The output, it's not the output of inHEART. inHEART produces the 3D model, and we are developing academic software that allows us to fuse the inHEART models with EP maps, to draw on these models targets, and to export these 3D targets as RT-struct files that are readable by platforms. But then the fusion with the 4D planning CT of used by to simulate the dose and to expand, to address the motion during breathing, and all that is done on other systems, proprietary systems that are already used for treating mobile targets with radiation therapy, such as lung nodules. But yes, we can use the inHEART solution to refine the target. if it was the question.
Thank you, Hubert. Thanks, Katie. So, Pierre, I have another question for you. I'd like to get back to the topic of the integration into electroanatomical mapping systems. And can you tell us a little bit about your preferred methods of image registration into those systems?
Absolutely. I think, Hubert, you have some slides on that topic, do you? But typically, it all depends on the access you want to have to the left ventricle. Obviously, two options: either you go retro-aortic or you go transeptal. And so, if you go retro-aortic, then the registration is done as shown on the left of this slide here. So in red, you have the aortic arch as defined by your CT scan or your MRI. And in light gray is the same aortic arch that has been fast mapped with the ablation catheter. This is on a Calto platform, so it's a catheter that is equipped with a magnetic sensor, and we're not using any multi-electrode catheter for that, just the ablation catheter. It's in fact more precise with the ablation catheter because you don't have the uncertainty that you may have with the PanTray, where the magnetic sensor is in the shaft, and then you have localization of the electrodes that is based on impedance. So I like better doing it with the ablation catheter itself. The important point here is to be very restrictive on the respiration curve, because if you don't take your points in expiration, then you're going to have a lot of variation, and your reconstructed aorta from the 3D system will look weird and very large. And so this takes about 5 minutes, and then you align the two aortic arches and you get registered. We have a final verification where we advance the ablation catheter in the LV down to the apex and make sure that it's not out of the cardiac model that has been reconstructed from imaging. If you go transeptal, if you choose to go transeptal, which we often do in elderly with quite some atherosclerosis, you know, there are always plaques in the aorta, and sometimes it's probably safer to go transeptal. Then in this case, we would fast map the pulmonary arteries and align the two models based on the pulmonary arteries. That's exactly the same process. We are as restrictive on the respiratory curves, and we get registration the same way. Now, I mentioned earlier that we should not use the, this is showing you in accelerated mapping, the fast mapping of the pulmonary arteries, well, the trunk and the branches, right and left. We also in this case use the coronary sinus. We don't always do that. Typically the pulmonary arteries are enough, and particularly the bifurcation is a very good constraint anatomically area to be used for this registration. I told you not to use the atria, and this is because we did that in the past and it didn't work. Simply, you get obvious registration issues doing that. Again, that's because they are acquired during the image in systole and in diastole with your ablation catheter if you try to map them quickly. So it simply doesn't work. That's really important to understand.
Good. Would it be prudent to use atrial geometries such as the PVs to optimize registration?
Yeah, again, even the PVs is not a good idea. It doesn't work really well. One potential explanation is what I just said. It's the mismatch between cardiac cycle phase for the acquisition with imaging versus the acquisition with your navigation system and ablation catheter. So no, it's not a good idea. We have to stay in the ventricles or in the large vessels like the aorta or the pulmonary arteries.
Okay, good. So can the physicians annotate the model by drawing lines and ablation tags before exporting into the mapping system?
Yes, sure. So this is important because what imaging allows is pre-procedural planning. So you can take a bit of time before the procedure to understand where the substrate is, what's the appropriate route, and also to pre-plan or prepare your ablation strategy. So let me walk you through how it works and what's available. So when the case is ready, you receive a notification, you go on your web portal, and then you have your list of patients. And each time you click on one, it opens this screen. So this screen is the review of your 3D model. You can check. So here there was only arterial on CT. If there was late GAD-MR or late iodine CT, it would have shown here. And you can expand that, and you can check what has been done with respect to segmentation. But more importantly, you can review your case. You can obviously hide and show structures as you wish, and you can also annotate the model by, for instance, leaving tags in certain areas, and then these tags can help you understanding and pre-planning your ablation procedure. For instance, in this case, so Pierre will get to that later, it's our current approach to address post-infarction VT is to target the channels of preserved thickness within severely thin scar. And using that, we define our ablation strategy only based on CT, and we can pre-plan that in the platform and then export it to any mapping system. So in the end, in the mapping system, this pre-annotation can be very interesting to be able to best see the catheters through the annotation. So you can navigate with an optimal visualization and without having too many structures overlapped, because you've already done the interpretation of your case, in fact.
Hubert, can you get back to these images and
Sure.
I noticed you had the papillary muscles mapped here. I mean segmented. Could you show them to us? I find it quite interesting. Typically, yeah.
Yeah. Well, here it was an apical infarct, so it's not involved in the arrhythmia, but for sure, having these PAPs is very, very interesting for multiple cases.
Absolutely, I remember cases where
yeah.
Yeah, I remember cases where it made a difference. It really helped a lot. So I think it's good to see.
We've had a question come in that I think overall kind of could go to Pierre Hubert, but the question is there good data showing increased efficiency and efficacy that could be shared with the administration of the hospital to make a case for the cost of inHEART?
Yes, I think so. Problem is that everything you demonstrate in a single center in a non-randomized fashion is not as strong as a multi-center randomized study, of course. But if you look at our experience, yes, it's pretty clear that it helps and it makes a difference. And so typically our recurrence rate, since we moved to image integration, has been reduced by a factor 2, so twice less recurrences for our VT patients after ablation. And something that is quite spectacular is the impact on the procedure duration. Now, this depends on how you use image integration. There are different strategies, and not all the centers are using them the same way. And so I don't know, maybe Hubert, you can take me to those slides now, because we have this question where we show the strategy. So what we thought, here in Bordeaux is that, so for years we've been, comparing our 3D maps showing the substrate from mapping with multi-electrode catheters to the information we've got from images. And it became very clear that in fact we had the same type of information. It's probably even more accurate when we use images, because there is it allows you to see what is happening in the wall thickness as compared to a mapping that is purely endocardial or purely epicardial, in where you have no insight on what is happening inside the LV wall. And so here, what we ended up doing in Bordeaux is that we have our color-coded map for wall thickness. Again, the dark red that is contoured in white here is the most dense part of the scar, because the wall thickness here is 1 millimeters. And then it goes all the way up to the bright yellow that is 5 millimeters. So the idea is that these dark red areas are very unlikely to play a role during VT, because their conduction properties are just too bad for that. And so the slow conduction area that sustain the VT circuit is more likely to happen in areas where there is a little bit more wall thickness, so that there are probably not just fibrosis, but also surviving bundles of muscle. And this is in the 2, 3, 4 millimeters range, where we draw these green arrows, as you can see here. So these are what we call CT channels. And then our strategy in Bordeaux is that we don't map with any diagnostic catheter. We no longer use multi-electrode catheters. We just fast map the aorta or the pulmonary arteries for registration purpose, as said before. And then we would take our ablation catheter directly to the images, to the CT channels. And we deliver energy there to block them. We make sure that we lose capture here. We pace after ablation at 10 milliamps and 2 milliseconds, make sure that there is no capture. And we manage to place the lesions in the thinnest part of the CT channel. Why are we doing that? Well, because we want to maximize the chance for a durable lesion. So after doing that, and only after doing that for all CT channels, we would check for inducibility. And so by doing so, the other positive aspect you can use to discuss with your administration in your hospital to justify the extra cost is that the procedure, the VT ablation procedure, if you follow this approach, is going to be very short. It's less than 2 hours as a mean, and the standard deviation is very short as well, 25 minutes, meaning that you have no bad surprise here. You pretty much know that your VT ablation case is going to last 2 hours. And so from a planification and efficiency and lab time, these are, things that a hospital director can understand. It means that you can have an extra pulmonary vein isolation, whatever procedure. And so from a cost issue, it probably makes sense.
That was great. Thank you for that. Another question that's come in is being interested in wall thickness, which is your view to use in a recent future ultrasound data. Is it something feasible or is it too demanding in your opinion?
Hubert, you want to take that one?
I didn't understand the question. So if you did, please go ahead.
Yeah, so ultrasound, I guess Matteo is asking us whether or not we could include ultrasound data in our reconstructed models. And the answer is yes, obviously yes. Now, question is, would we have more information as compared to what we have at the present time? The answer is not clear here. Something that could be fun is to explore the, let's say, smartest ultrasound data, such as speckle tracking, and that could be probably interesting from a research standpoint.
Or electromechanical wave imaging.
Electromechanical, absolutely. But when it comes to substrate identification per se, I think we're doing a better job with MR or CT.
But maybe to complement this question, the use of ultrasound is already part of the strategy of many of inHEART clients. In Bordeaux, we don't use for the intracardiac echo because for cost issues, because we can't reuse these probes. But we have many sites that are using that as their standard way of registration. So what Pierre showed using FAM is great. It works very well, particularly with these ablation catheters that are really accurately localized. But other sites, such as the Brigham or Ann Arbor, are using 4D ICE. So what they're doing is that they're mapping, they're first segmenting the entire cardiac anatomy from the ICE, and then they're registering the inHEART model and start working from there. And it's extremely efficient. But as Pierre said, this is anatomical information and also potentially real-time information, for instance, when ablating the papillary muscles or when there are contact issues. But with respect to tissue characterization, obviously there are reports where, oh, I saw a scar on ice. Yeah, great. But this is not a three-dimensional, very detailed description of the scar. And I wouldn't rely on that as we can with pre-procedural imaging.
So another question is regarding the late iodine phase. Is there any possibility to delineate intra-scar corridor channels like late gadolinium phase in MRI?
Well, I think this is a question that is equally complex with MR than with CT. I think with MR, the current size of the MR pixels are probably insufficient to reliably state MR can map channels of gray zone within dense scar in VT. I don't think it's true. I think 80% of the patients that enter a VT lab are patients with old infarcts where the wall can be as thin as 1 to 2 millimeters, and you can't image these walls with 1 to 2 millimeters pixels because you will have partial volume averaging and you will describe this very dense scar as gray zone. You're making mistakes. So we have a big issue of spatial resolution to detect the arrhythmogenic tissue with MR. And with CT, it's another issue. We would have the spatial resolution, or at least a bit better, because it's 0.5 millimeter for now. But the problem is that we have a lot of noise. So the way to threshold this signal in order to define what's gray zone, what's dense scar, is less robust than what can be done on MR. So I think both techniques should improve, and there are currently a lot of work improving MR in its ability to map the scar at high density, and particularly to robustify these thresholds for dense scar and gray zone by using extracellular volume mapping to calibrate the late GAD enhancement dynamic. And on CT, there's this very new development in photon counting CT that may very well change the game, because for the first time, we will have pixels of 100 micron in humans in vivo to characterize the myocardium. And this may unravel a new set of knowledge with respect to ventricular tachycardia and AFib, obviously.
Mm-hmm.
So, Pierre, you mentioned a little bit, the importance of randomized multi-center clinical trials. And as I understand it, the inHEART system is being assessed in one such study. Can you tell us a little bit more about this?
Yes, absolutely. So that's a project where inHEART collaborates with a larger consortium, and part of the funding is used to first randomized multi-center trial. So VT is not AF, and recruiting patients in VT trials is much harder, of course. So we limited ourselves to 120 patients as a target, half being randomized to the conventional approach of one of the 15 European centers participating, and it can be different among centers. And the other half, so another 60 patients randomized to the CT channel approach I just described. And you have on the left of the slide this model that shows you what this is about, if you forget in the meantime. So clearly, we don't have the access to the kind of money we would need to demonstrate a benefit on mortality or whatsoever. So we have the goal of demonstrating that these procedures are now going to be shorter and significantly shorter, and two, that they are more cost effective. So we will run some analysis on cost effectiveness here. There are two aspects where we could participate in reducing the cost in the arm that is using inHEART technology. Number one is that the procedures are shorter, and this has a major financial impact. Number two is that no extra catheter is needed. The ablation catheter is all you need. So this also is driving the cost significantly down.
And Pierre, and when are you expecting that trial to begin?
Yeah, we should get started anytime soon now. First quarter of this year, 2022.
Okay.
We have in
the very near future.
Absolutely.
Yeah.
Very exciting.
Some really exciting endpoints.
Just so you know, it was delayed because of COVID. So it has been funded for 1.5 years, but it has been delayed because of the funding in these European centers. Some were, not starting these type of projects.
Yeah. Understandable. Well, good. And it sounds like the endpoints are will help even answer some of the questions that have come up today, gathering that data. So good. Thank you.
Absolutely.
Well, Pierre and Hubert, it really has been another lively discussion here today with you. So thank you again for your time in making imaging protocol and workflows and engaging dialogue, and sharing your experience and expertise with the audience on the inHEART solution. And again, to all of the attendees who are joining us, we thank you for your questions. And certainly if you have additional questions, please reach out to the inHEART team at sales@inheart.fr. And if you missed the December webinar, which was another lively discussion, we also have the webinar on the inHEART website. That's www.inheart.fr. And there is a video menu option in the top nav bar. So be sure to join us. Also for our future webinar, we are doing a series of these over this coming months, and we'll have for our next webinar featured guest physician speakers who are going to share with us how they've incorporated the inHEART solution into their clinical practice. So I think that will again be another lively discussion with good insights and great visuals. So thank you everyone for joining us today, and we certainly look forward to seeing you all on our next webinar. Have a great day.